Hello, everyone. Today, I'll be giving you an overview of slap tears, a shoulder injury that can affect both athletes and non athletes alike, and can really impact shoulder function, causing significant discomfort if not properly addressed. We'll cover what it is, how it happens, what tests can be used, and how it's treated. First, let's understand what a slap tear is. This particular injury can be located at the shoulder, more precisely inside the glenohumeral joint. As we all know, the glenohumeral joint is a ball and socket joint where the head of the humerus fits into the shallow glenoid cavity of the scapula, or shoulder blade. Surrounding this cavity is a ring of cartilage called the labrum, which provides additional stability and cushioning to the joint. The labrum is also attachment site for the tendon that connects to the long head of the biceps muscle and for several ligaments. A slap tear occurs at the top part of this cartilage, where the biceps tendon connects to the labrum. But what exactly is a slap tear? SLAP stands for superior labrum anterior and posterior, describing the location of injury. SLAP tears can be classified into several types, depending on the severity and structures involved in the injury. Type 1 describes fraying of the labrum without significant detachment of the biceps tendon anchor. In a type 2 SLAP tear, labral fraying is accompanied by the detachment of the labrum and biceps anchor from the glenoid. Type 3 SLAP tears involve a bucket handle tear of the labrum without detachment of the biceps tendon anchor. And lastly, in a type 4 SLAP tear, we can observe a bucket handle tear that extends into the biceps tendon, detaching the anchor from the glenoid. Let's take a look to better understand the different injury types. The four different types you can see in the picture are the most common variations with involvement of the labrum and the biceps tendon anchor. However, other injury variations are possible due to the complexity of the shoulder joint and high potential of other structures being affected during the trauma. Looking at the data, SLAP tears account for 80 to 90% of labral pathology in the stable shoulder. However, they are usually seen in association with other shoulder pathologies and rarely in isolation. Type 2 tears are the most common and account for 55% of SLAP tears. In the athletic population, SLAP tears account for 1 to 3% of injuries in sports medicine centers and can be found primarily in the dominant shoulder of overhead and throwing athletes. Looking at the demographics, there is an age related effect in which older patients are more likely to incur a SLAP tear due to age related changes of the labrum. That brings us right to our next point, risk factors. As mentioned before, age can be identified as a significant risk factor. From the age of 35, the superior labrum is less firmly attached to the glenoid than in people under the age of 30. Other risk factors are physical labor, such as jobs or sports that require repeated overhead motions or heavy lifting, and shoulder instability. Now, how do these injuries happen? There are two main ways. A slap tear can be caused by trauma, such as falling on an outstretched arm, a sudden pull on the shoulder, and shoulder hyperextension, or repetitive stress like throwing a baseball or swimming. Sometimes, age related wear and tear can also lead to fraying or tearing of the labrum. These pictures show some of the most common mechanism of injury seen in athletes. We see repetitive stress in the top left picture, a fall on an outstretched arm in the bottom left picture, direct trauma in the top right corner, and a sport where traction on the shoulder joint is a common occurrence in the bottom left picture. The following video will give you a better impression of what is happening inside the joint. So, what does a slap tear feel like? Patients with a slap tear often report deep shoulder pain, especially with overhead movements or twisting the arm. They might also hear or feel a clicking or popping sensation when moving the arm, notice weakness during activities, or even feel like their shoulder is unstable. During the inspection and palpation, the clinician will most likely discover a loss of internal rotation range of motion, decreased strength and endurance in rotator cuff and scapular stabilizer muscles. And in severe cases, he might be able to observe muscle atrophy of the biceps on the affected side. Athletes also often report a reduced throwing velocity in practice. Before we're looking at the examination process that is used to diagnose a slap tear successfully, we'll take a peek at potential differential diagnoses. In this case, possible differential diagnoses are shoulder impingement, a rotator cuff tear, and proximal biceps pathologies. These injuries all present with similar signs and symptoms but require different treatment plans, which is why an accurate diagnosis is essential for a successful treatment. To diagnose a slap tear, doctors will start with a physical exam and may recommend imaging tests like an MRI. In some cases, an arthroscopy, a small surgical procedure, might be used to get a closer look. Starting with manual muscle testing, there are three main muscles we want to test if we suspect a slap tear. First, the biceps. I start by putting my hand on the bicipital groove to palpate for possible tenderness and put the patient's arm in a supinated position. To cover all biceps functions, we'll start with flexing the elbow, followed by shoulder flexion. After looking at his active range of motion, I place his arm in 90-degree of elbow flexion and 45-degree of shoulder flexion for the first break test. I am applying downward pressure, focusing mainly on extending his elbow. The second break test is at 90-degree elbow flexion, with the forearm supinated and the shoulder in a neutral position. This time I am applying pressure on his forearm, trying to pronate the arm. For the concentric part, I will have him go through the entire motion, and I apply resistance throughout the movement. The second test is targeting the supraspinatus muscle. Again, I am putting my hand on top of the shoulder to feel for any clicking or popping during the test and start with the active range of motion up to 90-degree of shoulder. Abduction. For the break test, I am flexing his elbow to prevent other muscles from helping and place the arm in 45-degree abduction. After that, I am again applying resistance throughout the complete motion for the concentric test. The last muscle we want to take a closer look at is the subscapularis. Due to the unique test position with the arm behind the back and the shoulder in internal rotation, we can easily detect any loss of active range of motion for internal rotation, which is common in patients with slapped ears. This time, I am putting one hand on the anterior side of the shoulder joint for stabilization and using the other hand to palpate for the subscapularis muscle. For active range of motion, the patient is asked to lift his hand of his back. If he is able to complete this motion without excessive forward movement of the shoulder and upper body, I am applying a little resistance for the concentric part of this test. In all three tests, we are looking for discomfort, pain, clicking or popping, or the inability to resist pressure. For special tests, a combination of two sensitive tests and one specific test has been proved to be useful to diagnose a slap lesion. For the purpose of this presentation, I chose the compression rotation test and O'Brien's test for the sensitive tests, and Speed's test as a biceps provocation test. If one of the three tests is positive, this will result in a sensitivity of about 75%. In the case of all three tests being positive, this will result in a specificity of about 90%. Starting with the O'Brien's test, the patient is in a standing position with the elbow extended. I am putting one hand on top of the affected shoulder to palpate for possible abnormalities. The affected arm is placed in 90-degree of shoulder flexion, 15-degree of adduction, and internal rotation with the thumb pointing down. In this position, I am applying downward pressure the patient has to resist. If this position elicits any pain on the posterior side deep in the shoulder joint, I rotate the arm into external rotation with the palm facing up. Pushing down again, the pain should be less in this position. The second sensitive test is called compression rotation test. The patient is in a seated position with the elbow at approximately 90-degree of flexion. I am putting one hand under the elbow to support the arm and my other hand again on top of the affected shoulder. In this position, I am pushing the humerus up into the shoulder to compress the labrum, putting his arm in 45-degree of abduction and rotate the arm clockwise and counterclockwise. The test is positive if the patient reports any discomfort, pain, or clicking sensation. Speed's test is used to detect pathologies of the long head of the biceps. For the test, the patient is standing with the elbow extended and the arm fully supinated. I am again putting one hand on the top of his affected shoulder, and with my other hand, I am resisting shoulder flexion. During the motion, I can use my top hand to palpate for any tenderness over the bicipital groove. As a second part of the test, the patient is placing the supinated arm in 90-degree of shoulder flexion and resisting my downward pressure. If the patient reports pain, the test can be repeated in a pronated position, which should lessen the pain significantly. As a last step of the examination process, imaging, such as an MRI with contrast, is often used to confirm the diagnosis. Sometimes arthroscopy, a minimally invasive surgical procedure, is needed to directly visualize the injury. In the picture, you can see the comparison between a healthy shoulder and a patient with a slap tear captured with an MRI. As for treatment, it depends on the severity of the injury, accompanying injuries, age, and the activity level of the patient. Many mild cases can be managed without surgery through rest, anti-inflammatory medications, and physical therapy. But if the tear is more severe or doesn't respond to conservative treatment, surgery may be needed to repair the damaged tissue. Especially for athletes, surgery is often recommended because of the high stress that is being placed continuously on the shoulder joint in order for them to return to play as soon as possible without a reduction in their performance. However, return to pre injury performance rates for athletes vary greatly and don't only depend on the type of treatment. Recovery is just as important as the treatment itself. Physical therapy helps restore strength and mobility, and patients are often guided through a gradual return to normal activities or sports. The whole process can take up to 9 months before pre-injury level of activity can be continued. In summary, while a slap tear can be a frustrating injury, Early recognition and proper treatment are key to achieving a successful outcome. Thank you for listening, and don't hesitate if you have any questions.